Good afternoon and welcome to the Australian Centre of Value-Based Healthcare's webinar, Value-Based Healthcare and Environmental Stewardship, a global approach to a global problem. I'm Olivia Pantelides and I'm the Executive Director at the Australian Healthcare and Hospitals Association, and it's my pleasure to be your host today. But before we get underway, I would firstly like to acknowledge and pay my respects to the traditional owners of the many lands on which we meet, and recognise their continuing connection to land, water and culture. I am currently on the land of the Wathaurong people and pay my respects to their elders past, present and emerging. I think we seem to be having a few technical difficulties, but I'll continue on as we try to establish our slides. Here we go. Great, thank you. This year, the AHHA and the Australian Centre for Value-Based Healthcare are engaging in a program of work that centres around the National Health Reform Agreement Long-Term Health Reforms Roadmap, signed off by all health ministers and published in October, which demonstrates a commitment to value-based health system reform. The AHHA has a long history of involvement in the value-based healthcare space, and as we are engaging with members in local and global communities shifting together towards value-based healthcare, the feedback we consistently hear is that we need to better understand how we measure what matters and what this means in practice and how this is different from what we already do. And as services and jurisdictions across the country begin to adopt value-based healthcare, we need to together ensure all parts of the system are working with shared understanding about what it means to measure what matters. And climate change for us is the defining issue of our time. It poses a significant risk to health and health services. We are not only facing the growth threat of natural disasters and the associated effects of injury, disease, death, displacement and trauma, with physical, emotional and financial effects, as seen very recently and even today with the Queensland and New South Wales flood emergency. But health services are being placed under increasing pressure. Pharmaceutical and medical supply chains are affected, and health professionals and emergency professionals are impacted personally, limiting their ability to respond. Climate change matters, and as such needs to be a focus of measurement and reform as we shift towards value-based healthcare implementation globally and across Australia. With health systems having to keep people healthy at the very core and the reason for being, how are health systems taking responsibility for protecting health? Today's presentations were initially delivered at the International Hospital Federation World Hospital Congress from two leading climate health experts in Australia on ways in which health systems can demonstrate leadership in understanding and mitigating the impacts of climate change. First, we'll hear from Dr Arnagretta Hunter, Clinical Senior Lecturer, Human Futures Fellow at the Australian National University, on how the principles of value-based healthcare and targeting low-value care can help reduce the carbon footprint on our health system. Then we will hear from Vicki Bennett, Head of Metadata and Classifications Unit at the Australian Institute of Health and Welfare, on the importance of measuring and monitoring the environmental and climate change impacts on health and of delivering healthcare. And we're fortunate enough to have Vicki, who will also be joining us in person for a live Q&A session at the end of the presentations. So if you have any questions throughout, feel free to include them in the Q&A function you will find at the bottom of your screen. But first, as we load this presentation of Dr Arnagretta Hunter, a little bit about her. Dr Hunter is a physician and cardiologist with a focus on preventative care. Dr Hunter is a senior lecturer at ANU Medical School and Human Futures Fellow for the ANU College of Health and Medicine. She is the chair of the Commission for the Human Future and member of the ANU Institute for Climate, Disaster Science and Energy Change. Her research interests include the health impacts of climate change, the environmental determinants of cardiovascular disease, and health impacts of natural disasters such as bushfires. She writes on health policy, public policy, and particularly on the impact of the environment on our health. We'll begin the presentation now.
My name's Arna-Greta Hunter. I'm a cardiologist and the Human Futures Fellow at the College of Health and Medicine at the Australian National University in Canberra. And I'm coming to you virtually from Canberra at the end of one of our lockdown periods. It's a wonderful time for us to rejoin the global community again at what is quite a remarkable time in our global history. Firstly, I'd like to acknowledge the Ngunnawal and Ngambri people, the Indigenous Australian peoples on whose land I'm currently sitting. It's important to acknowledge the significance of our Australian Indigenous heritage, that our Indigenous peoples never ceded their lands or their culture, and to reflect on the remarkable understanding that is generously shared by Indigenous peoples, particularly reframing health and wellbeing in a deeply holistic way that encompasses both people and place. I'm going to speak today about climate change in the health system. I'm particularly interested in value-based healthcare and low-value healthcare, and whether putting those two things together might help us to reduce the carbon footprint of our health system. Climate change and health are deeply connected. We have had a tendency in our health system to consider human health through the biology of disease. This pathological and biological focus has seen us focused on drugs, procedures, and interventions in a quest to improve human health and wellbeing. Increasingly, we are aware that human health and wellbeing is beyond biology, that the social determinants of health and wellbeing play a dominant role in our health. The final element of this framework is, of course, the environment. Temperature, air quality, food and water security and access, where and how we live. The environment is another framework for health and wellbeing. Anthropomorphic climate change sees rising global temperatures. This graph on this slide is from the 6th assessment report from the IPCC that was released earlier this year. The rises in global temperature will increase the weather extremes and particularly increase the likelihood of natural disasters. Speaking today with a global audience, I'm particularly aware that every single one of us will have had a natural disaster in recent periods that was made statistically more likely by global warming. In the Australian context, of course, we had a textbook case for climate change associated natural disasters with the black summer that it was experienced over 2019-2020. The devastating fires started here in Queensland and slowly extended south down the Great Dividing Range through New South Wales into Victoria and saw profound impacts on our natural environment. Impacts on a native wildlife, which was devastating, and a human health impacts, which were seen across our healthcare system, affecting all of the different types of health outcomes, with almost half of our population exposed to hazardous levels of bushfire smoke through that devastating summer. Climate change and health are here and now. Direct and indirect health impacts come from climate change. We will see increasing mortality from heat and from temperature, from food and water security impacted by drought and other extreme weather, and altered morbidity and mortality from changed patterns of our infectious diseases. Of course, there are also indirect health impacts from population displacement or changes to impacts on essential supply chains, leading to insecurity of food, water, and other essential products. These are just some of the myriad of ways in which climate change will increasingly impact on human health and wellbeing. Climate change is the greatest challenge of the 21st century, threatening human health and development. The longer we delay action, the greater the risks to human health and lives. This is, of course, from the World Health Organization in 2018. The time to act on climate change was a decade or more ago. The next best option is, of course, to act now, to take all of the decisions that we make in our lives, and particularly within our work and activity in the healthcare sector, through the prism of climate change and the impact that it has on our health and wellbeing, both now and into the future. So let's start by thinking about greenhouse gas emissions and where they come from. Internationally, greenhouse gas emissions are divided into three different sources. Scope 1 emissions, which are the sort of emissions that come directly from business activity. If you're running a factory, then your Scope 1 emissions can be significant, particularly if you're running something like a coal-fired power station. In the healthcare sector, Scope 1 emissions come from transportation and other industrial processes that can be part of running a hospital. Obviously, many hospital and healthcare facilities have a carbon footprint that comes from the different machineries that can be used. The second issue is Scope 2. Scope 2 emissions are indirect, and they come largely from our sources of energy, things that might heat and cool the infrastructure that we exist in. If we're buying 100% renewable energy and that covers both energy, heating and cooling, then we can rapidly decrease our scope 2 emissions, which is quite profound and has flow-on effects. Several jurisdictions around the world have achieved this in their healthcare sector and in their community, and that includes the Australian Capital Territory where I'm based. The last part of the equation is almost certainly the most complex, and that's the scope 3 emissions. Scope 3 are the indirect emissions that come from the supply chain, the embedded carbon footprint that covers both the production of goods and their transportation. If you're using vegetables that you grow in your garden, the scope 3 emissions might be from the seeds or the seedlings, but they're likely to be negligible. If you're buying an MRI machine manufactured in a number of factories in different locations, and you're buying it to bring it from overseas, or you're buying vascular stents or orthopedic prostheses, the scope 3 emissions are a significant factor. Scope 3 includes all of the elements of that harvesting and manufacturing process, the transportation and the supply chain carbon emissions. For most of us individually, scope 3 emissions are the major component of our carbon footprint. That's true in our lives domestically, as well as in our professional experience. The number varies, Scope 3 emissions are the major component of our carbon footprint, and this is the case in healthcare too. When considering this, it's useful to tie together consumption of stuff and the carbon emissions that are scope 3. Around the world, there are different fractions that are attributed from healthcare to the nation's overall carbon footprint. The number varies from around about 5% to 10%. An assessment that's been done here in Australia by Malik et al. That was published in the Lancet Planetary Health in 2018 estimated very reasonably that 7% of the Australian national carbon footprints from the healthcare system. And so where do we get that from? Well, it's very reasonable to assume that 7% is a good number, at least partly because the healthcare sector employs at least 10% of the Australian population. When we extend it to our caring population, those who are working in nursing homes and other care facilities, that in fact employment in that healthcare sector more broadly is a large minority of the Australian working community. Economic activity and employment are often reflected in carbon footprints because of this relationship with scope 3 emissions and consumption-based activity. So we estimate that about 7% of the Australian carbon footprint comes from healthcare, and that 60% of that carbon footprint is from consumables or from direct consumption of stuff. Other proportions that are clearly worth mentioning and worth focusing on include the utility, so the sources of our electricity and energy, the travel that we do as part of the work that we do, and the waste system. And these are all potential targets for improving the greenhouse gas emissions of the healthcare sector. So what can we do to address the environmental impact of healthcare? It's obviously important to look at renewable energy use, to reduce waste and to see what we can do about recycling. There is, however, another element of the equation. Can we change consumptions around healthcare? Would that adversely impact health outcomes? Or could it be that reducing health system consumption actually improves health and well-being? Value-based healthcare is a really interesting framework in this context. There's a growing movement around the world, and one we're very proud to be part of here in Canberra and in Australia more broadly, that's exploring a shift towards value-based healthcare. Value-based healthcare provides a patient-centred approach to the design and management of health systems. The central elements to value-based healthcare include being patient-centric, being outcome-focused, and taking a whole-of-system approach. Value-based healthcare may see patients trying to choose to avoid surgery if possible. There's some great examples that are out there, including the treatment of advancing osteoarthritis of the knee. There are a number of trials in progress and previously published that give patients the option of treatment with physiotherapy and exercise to avoid surgery, and that patient-centred progress and outcomes in that context are often preferred in contrast to the surgery. If a patient chooses to enjoy regular exercise and physiotherapy, perhaps with a personal trainer or an exercise physiologist, we know that there will be a small carbon footprint associated with that activity. But I think it's easier to negate the carbon footprint there using active transportation or carbon neutral transportation and carbon neutral electricity systems compared to the carbon footprint of a joint replacement. And so it's quite interesting here to be guided by the patient choice and to be very much patient-centred, giving people practical suggestions and ideas, and particularly giving them choice in terms of the approach that they take to their problem, in this case, osteoarthritis of the knee. We can look at similar sorts of interventions in cardiology. I'm a general cardiologist in clinical practice. There's an increasing amount of evidence that would suggest medical management of stable coronary artery disease is preferable, or offering medical management is a perfectly reasonable starting point. Often it would include an structured exercise program, and we know that exercise programs and supported conversations can be, one, carbon neutral, and two, benefit patients in ways that extend well beyond the management of the plaque inside the coronary artery. It is, of course, tremendously important to note that knee replacement surgery can be revolutionary for patients. That coronary artery stenting and bypass surgery can significantly transform a patient's quality of life, and that treatment with drugs, procedures and surgery have a real role to play in our healthcare system. And they can positively impact on our both quality of life and on survival. These treatments have a clear role to play. However, we do know that there's a problem with low-value healthcare, and that we have good data to show that we overuse many of these sorts of routine interventions and even the more invasive sorts of medical treatments. And if our goal is outcome focused, if we want to be led by our patients and what they regard as important, quality of life, for example, we might find effective interventions that have a much lower carbon footprint associated with them. We need to talk about low value and no value healthcare. Low and no value healthcare offers little or no benefit and still risks that iatrogenic harm involved with hospitalisations and procedures. Research done here in Australia has shown that around 30% of the healthcare that is delivered is either of no value or little value or no benefit. Perhaps even more concerningly, that 10% of healthcare that's practiced is of no value. When we're talking about examples of low value healthcare, overdiagnosis is a key element. Screening for benign conditions, screening in a situation where we might find that the pros and cons of that screening process are significantly more complex, and that often lead to compounding, cascading sequence of tests and investigations that are not focused on improving a particular person's quality or quantity of life. The quality of the healthcare system, which is often very difficult to know, is a dominant feature in the delivery of or the avoidance of low-value healthcare. Early recognition and conversations with patients about pros and cons of screening tests and other procedures are a key part of the overall picture here. When I think of examples of low-value healthcare, I'm again back in my profession of cardiology, that some of the work that we do on coronary artery disease and in cardiac rhythm disturbances may not contribute in a meaningful way to the patient's quality or quantity of life. Medical management is an important mainstay of some of the things that we do, and yet in Australia, a blocked artery that's identified with testing is often or routinely treated with coronary intervention. This Orbiter trial offers quite a remarkable view of this when we're thinking about it more broadly. They performed a sham coronary stenting and inadvertently demonstrated that coronary stents carry a placebo effect and don't offer clear symptom relief for patients. The pros and cons of coronary intervention have been well explored in a multitude of randomised controlled trials that show there really isn't a significant influence between medical management, coronary intervention with either stenting or bypass surgery. We need to be able to talk about that in a detailed way with our patients. When we look at it through the environmental prism of the carbon footprint, it again adds weight to the tremendous importance in having these balanced conversations as to whether to proceed or not with invasive treatment. A similarly difficult conversation can be around issues like breast cancer and prostate cancer screening, the complex analyses that have been done internationally showing that some of these routine screening procedures are much more complex than they seem. These problems prompt and often need a nuanced and more complex, often emotive clinical discussion. And I find myself wondering how much the healthcare system might reward these conversations with our patients that are at the centre of the sort of decision-making around consumption, treatment and tests. In healthcare system financing, we're dominantly remunerated by clinical activity, particularly procedures and consumption. Much less well rewarded for a more nuanced, patient-centred conversation which is focused on that individual's well-being. The shift to patient-centred outcomes may be one of the key elements provided by a value-based healthcare approach in trying to remove the low-value healthcare or no-value healthcare from our system. First, do no harm is an oft-used phrase, but in fact, in this discussion of the health system's carbon footprint, it is deeply resonant. Harm neither person nor planet. Consider the patient at the centre of treatment decision and choose to care for the planetary impacts at the same time. Use health system resources wisely and, when able, in a low carbon way. Clinical discussions should centre on quality of life and life expectancy gains, sometimes which can be quite small. Not doing something can be a powerful intervention, and talking about it is key to good clinical practice. Conversations with patients are generally not harmful and clearly can be carbon neutral. Personalised attention and support from healthcare practitioners is often very well received by our patients. Talking about preventative therapies through changes to activity and exercise, nutrition and food consumption, social supports and general well-being can significantly improve the patient's health, not just for the particular concern of the moment, but more broadly. By focusing on enabling our health and hospital systems to be patient-centric and outcome-focused, using the models developed with value-based healthcare, we can reduce the carbon footprint of our healthcare system by reducing low and no-value health interventions. This would simultaneously offer us a healthier and happier population and make meaningful action on the health sector's contribution to climate change.
I think that was an excellent presentation from Dr. Hunter there, and I think what really resonated was do no harm to the patient nor the planet. So now we will hear from Vicki Bennett. Vicki Bennett is the head of Metadata and Classifications Unit at the Australian Institute of Health and Welfare, where she has held a number of different roles over the past 13 years. She was also previously the manager of the Information Strategy section at Medicare Australia. Vicki has a degree in Health Information Management and a Master of Health Informatics, and has a diverse career both domestically and internationally. She has worked extensively across the Pacific over the past 15 years, as well as lectured at a range of universities. We will have her presentation shortly. Here we go.
I am the head of the Metadata and Classifications Unit at the Australian Institute of Health and Welfare, and I'm speaking to you today from Canberra, Australia. I would like to be in Barcelona instead, but here I am in lockdown in Canberra due to the coronavirus. But I would like to start by acknowledging the traditional custodians of the land on which I meet, the Aboriginal Ngunnawal people. The Australian Institute of Health and Welfare is our national body for reporting on health data in Australia. I'm going to be speaking today about the importance of health data in understanding and reporting on climate change and environmental effects on human health. Being able to effectively report on the impacts of climate change on the health populations is an emerging issue. You can't manage what you can't measure, is something I like to say. Collecting and collating information on the health impacts of climate change enables governments and health systems to plan for and manage these new and emerging challenges. However, methods for measuring and monitoring of environmental and health change impacts of delivering care are beginning to be developed, but they are still in their infancy. Collecting and collating information on health outcomes has a long history globally, especially for mortality. Those of you who've studied epidemiology might know more about this, but we have been collecting mortality data globally from as early as the 1850s. In 1948, the International Classification of Diseases and Health-Related Problems was first adopted by the World Health Organization, and there's been roughly a revision to that collection system about every 10 years. The system we're using at the moment is the 10th edition for mortality, which was first released for public use in 1992. As you can tell, a bit out of date. And then in 2019, the 11th edition was accepted by the World Health Assembly with a planned implementation for 2022, although we acknowledge the world would not move to that globally at the same time. So we also collect in some countries good information on morbidity or disease information, but it is certainly not as well done as we have for mortality. Some countries do have excellent morbidity data collections like we do in Australia and many other developed OECD countries. And we have our own modification of the ICD-10 called the ICD-10-AM, the Australian modification. And these national modifications allow us to capture extra clinical granularity and are able to readily be updated to include new codes to meet emerging needs. You can see below some examples of what we are able to capture in external causes that would help us to be able to report on climate change issues such as exposure to excessive natural heat or exposure to excessive natural cold. The coverage of ICD of health impacts of climate change currently in the ICD-10, it does have a number of codes that can allow for us to capture information for both morbidity and mortality in understanding the underlying impacts of climate change on health. For example, as on a death certificate that is coded with the ICD-10, you are now able to capture information on things like heat stroke or sunstroke as that underlying cause. So data, there is some data available in most countries on this. Some local research that is being undertaken in Australia is starting to try and look at health outcomes that we can measure using existing ICD code sets. And these can be related to things like respiratory health, heart health, brain, heat, cold, burns, deprivation, and then some of our external cause codes around environmental and social issues, which are also important to report. I mentioned earlier ICD-11, and it certainly is out there for future use, and many countries globally are planning for its implementation. It is a significant advancement on the current ICD-10. It has over 8,000 codes in its foundation. It is designed to be integrated electronically into information systems, which should allow it to be more electronically capture of data in most systems. It also has supports the customization of different what they call linearizations or use cases, perhaps for specific areas. And so perhaps climate change and environmental health could be one of those for the future. And it also supports and updates the terminology and use, for those of you who might know anything about it, that supports the dramatic medical and technological advancements that we have seen in healthcare since ICD-10 was first released in 1992. And it certainly includes more ability to capture impacts of health and climate change. And where I work at the Australian Institute of Health and Welfare, we are a WHO collaborating centre for the development of the international classifications. We are also developing globally a thing called the International Classification of Health Interventions, and it is also planned for rollout globally into the future. And you can see there in the list of its contents that it has a whole chapters 22 to 27 interventions designed around environmental interventions, and that public health interventions generally have a specific target in this area. It allows us to capture information, it will allow us to capture information on things like outdoor air quality that have impacted on an episode of care. And the use of a base code with additional strings added to it allow us to create a much more granular clinical picture of what has happened and what is happening to people. But moving away from what we can capture, I think it's more important that we focus of what we're doing with the data that we can capture and that we do capture in many countries. I've worked in many developing countries and much data is captured, but very little is used. And I think that's where it's important to understand how we use data to measure impact. Many global entities are trying to measure the impact of climate change. And this is just an image of a link to the OECD Key Environmental Indicators document. Each of the indicators outlined in this document start with a statement that notes that the reason that they're so important is because we need to understand their impact on human health. As I mentioned, I've worked globally a lot, and one of my roles at the moment is to be a WHO advisor to the Pacific Health Information Network. And under that banner, I am, and through my day job, also doing a review of the Pacific Islands Healthy Island Monitoring Framework. The reason that I'm highlighting this today is that we know that climate change is a challenge for all countries, but more so for some. The small island nations of the Pacific are in particular need as they are facing the brunt of changing weather patterns, including cyclones and rising sea levels that impact not only their landmass, but their fishing areas. So what is the Healthy Island Monitoring Framework? Well, in 1995, the Pacific Health Ministers declared that they had a vision for healthy islands, that where children were nurtured in body and mind, environments invited learning and leisure, people work and age with dignity, and more importantly to this presentation, ecological balance is a source of pride and that the oceans are sustained and protected. In 2015, they recognised that if they were going to try and progress towards this vision, that they needed a way to measure how they were going and monitor that. In response to that, they delivered an indicator framework, and the fourth pillar of that framework is completely related to ecological balance. And in the framework, there are 5 mandatory indicators, and these include populations using clean fuel for cooking, heating and lighting, resilience to climate change and national disasters, populations using improved drinking water sources, populations using improved sanitation facilities, and the number of vector-borne disease outbreaks, which includes things like malaria. And these all help understand how people are living within a safe way within their current ecology. There were also optional indicators, 9 of these, which I won't go into detail for, but they do include things like the share of coastal and marine areas that are protected, the area of public and green space as a proportion of the total city, forestation and cultivation, how solid waste is dealt with. And these are not insurmountable issues for small island nations that are less developed than many of ours. Returning to not only the need of countries to understand how they're managing climate change and its burden and impact on health, I refer to some of the other presentations in this session that talk about the need to collect information on environmental impacts of delivering health care. In Australia, we have a thing called the Australian Health Performance Framework, which is the diagram outlined at the bottom, which you won't be able to read, but feel free to have a look at it on our website. Health systems themselves are not currently collecting much data on the environmental impact of their service delivery. Our Australian Health Performance Framework currently has no indicators related to this. We know that we need to do more about this in the future, but we need to get good agreement from governments that they understand that the impact of delivering healthcare to the environment and thus to the health outcomes of their clients, patients, and the whole population is important. We must do more in the future. We must do it nationally and we must do it globally so that we can understand the impact that we are having to our populations, not only through the delivery of healthcare, but through the way we impact and interact with our environments. As I said at the beginning, I work at the Australian Institute of Health and Welfare in Australia. We do have an area that reports on environmental health. We have had many environmental impacts, and Australia is one of those countries with extreme weather conditions. We have bushfires, we have cyclones, we have hailstorms, we have earthquakes. We are well equipped to help globally. Please feel free to be in contact with me, and I can put you in contact with those of my colleagues who are working more specifically in this area. And thank you for your time today.
Well, that was an excellent presentation. And as I said at the beginning, we are very fortunate to have Vicki here with us today. Hi, good afternoon, Vicki. Great to see you.
Thank you. Welcome, Olivia. Thanks very much, Olivia. Thanks for having me today.
Absolutely. So I've just, for anybody that's interested in any questions, please feel free to type them in the Q&A or the chat box and we'll monitor that. And whilst we're waiting to see if there are any, I'll kick off with some of mine for you, Vicki. Our work with the Deeble Institute made some recommendations around climate-related health outcome data in order to drive improvements. Is there any work currently being undertaken at the national level to support this type of data-driven improvements?
Yeah, there is. As I mentioned sort of at the end of that video there, the AHW, we have a whole team that works sort of in this space, population health and environmental health unit. It's not the area that I run, but because my team does a lot of the work that sort of helps come up with the specifications for indicators and the data sets, the definitions of those things. We work quite closely with that area. I know that there is some work happening collaboratively between, say, us and some of the other universities in Australia that have got particular research focus in this area. So I guess as the sort of national data custodian for many of the sets, you know, we often get asked to participate in work that others are perhaps coming from a research perspective. I think it'd be fair to say that environmental health data more generally in Australia has to date been more of an area for research than administrative data. It's been more about collecting information to answer particular research questions, but it is definitely an area of importance, and you know, we are starting to focus at the Institute more strongly in this area.
And what advice or what can the health system do to build a case to support inclusion of climate and health metrics in national reporting?
I think the answer to that is pretty tricky because if you imagine yourself as a hospital administrator or a manager of a health service, it's probably not the thing at the front of your mind. I do think we need the evidence base to help those who do operate and manage health services to know why it matters. You know, health services are quite heavily, there's a heavy dependence on them to report a lot of information through multiple funding mechanisms, through just state and territory health department, Commonwealth department. So people are sort of already sort of heavily burdened with reporting. So I think we have to definitely make the case about why it matters. You know, the conversation around low value care is the sort of argument to say, you know, there's also, you know, obviously for people like that, if you're running a health service, you know, could I save money through, you know, providing higher value care is a good argument. But I think there are no good ways that exist in our administrative data, no natural places just to go to get information on this. I was thinking about this the other day. We do a lot of reporting around hospital cost, and the National Hospital Cost Data Collection is one example of that. And we do try and understand what hospitals are spending money on. Maybe we could be looking at how much they're spending on travel and transport, things like that, waste. But there's no simple metrics available for us right now.
Thank you. We have a question from one of our attendees, so I'll go to that before I continue on with mine. It was mentioned that ICD-11 MMS is designed to be integrated electronically into information systems. How is this implemented at the moment?
In Australia, it is not. We are not there. We are, and that is the area that my team runs, is the classifications work. We are establishing a task force for Australia to look at ICD-11 and to undertake whatever activities are necessary for us to make a decision about in which cases it may be fit for purpose and how we would go about implementing it. As you can imagine, if you come from a hospital sector, you will know that we use ICD-10AM as part of a suite of tools with the ARDRGs to fund hospitals. Undoing that funding system and replacing the 10AM component with 11 is a big undertaking and has enormous impacts on what is a well-established system. I do think there'll be opportunities for us to perhaps try ICD-11 implementation in more greenfield sites, like maybe aged care is an example of something I've been thinking about, how we get better clinical information out of aged care by using ICD-11. Which could be integrated. So it is at its foundation like a terminology, and then the MMS creates the classification structure. Very happy to give another whole talk about all of that if you need to.
Excellent, thank you. Now I'll move on to my next question. Please keep them coming if you have questions as we go on. You mentioned that we currently don't have any mechanisms in place in Australia to capture any data information on how the health system is contributing to climate change. How do you think we could go about developing these types of mechanisms?
Really tricky one, isn't it? I mean, like when you think about what it is that we do that would impact climate change, it is things like patients travelling excess distances to access services, or obviously the provision of unnecessary service, increase in the use of consumables, COVID, how many masks have we wasted and the cost to that on the environment. There's a lot of issues there. So there's no one short answer to how we would improve that collection. But without the metrics, as I said at the beginning of the presentation, we can't manage what we can't measure. So we do have to be clever about it. I think data should be collected as close to source as possible. So I would encourage different parts of the health system to think about what it is that they could measure that would start to help them at a local level understand their impact on their environment. Do we need to be keeping lights on 24/7 in offices that aren't used? Or, there are lots of things people can do that we all do as individual consumers. How much more could we be recycling out of our hospitals? Because most things go to general waste. Having elderly parents who've been in and out of the health system over the last few years, I see what goes in a rubbish bin that I would never put in a general waste bin at my house. It would go in recycling. So there would be things that you could start to measure, I would imagine, but it does need to be considered, I think, at the point of care in the service settings. How we then could create some national standards around that and aggregate it up, that is a much bigger picture. But having worked at the coalface in hospitals and as an administrator, I think there could be some metrics at the local level that we start to think about. There's a lot of unnecessary travel. Can we be using telehealth a hell of a lot more than we have been? I was pleased in the budget last night to hear that telehealth is now embedded and continued. That's a great improvement for those, particularly who live in regional Australia, who've been required to travel many long distances, including, aeroplane travel just to have a specialist consult that doesn't require any biometric measure, So there's lots of things that we could be doing better in that space, I'm sure.
Thank you. And do you think there's any momentum within the government and the health system to make this happen?
Look, I think right now, the current federal government is looking towards an election. The health system is dealing with COVID, and I think right now it is very difficult for us to. This might seem a little bit left field. It shouldn't, because the planet can't wait for us to deal with our own issues. But I do think that what we can be doing in the meantime, while we can't get the focus on it that we may want, is to do all of that, creating the evidence as to why it matters. Because I think we need a strong rationale that the benefits, and again, in the health sector, I always say, follow the money. If you want data, follow where the money flows. I think one of the biggest opportunities is the cost benefit of a value-based healthcare environment. People may not change the way they do things just because it's good for the planet, but if it does save them money, you've got an extra carrot or stick, whichever way you see that. I think that's probably the way to achieve sort of change is to use the concept of value-based care.
Agreed. You mentioned working on Pacific Island Healthy Island Monitoring Framework. Can you tell us a little bit more about this work? What's been the effect of measuring and monitoring this ecological data over time in the Pacific, and has it led to increased action in these areas?
Probably the short answer is no. I think that the actual Healthy Island monitoring vision is still a very strong one for the Pacific themselves. Obviously, I mentioned, that they suffer more from the impact of climate than many of us. Global warming impacts them, rising sea levels. There's some countries that don't exist anymore because they have gone underwater. The indicators that I referred to in the presentation are what were defined in the framework back in 2015. My team is doing some work to try and review and potentially recommend some alternative measures to those, because they're very poorly reported. They're very difficult to report. I mean, resilience to climate change. How do you measure resilience to climate change?
Mm-hmm.
It's difficult metrics. I've been talking with some Australian and international colleagues about things like, could we be measuring something like the health system's ability to manage a natural disaster? For the particular, if you're a particular Pacific Island country, you cannot, individually stop global warming. You're not going to have a metrics like, reduction in global warming by X%, but they could be, from a health sector perspective, thinking about how they manage any of those climate impacts. Have they thought about the location of health services and whether they could be on higher ground? So, like when the volcano erupted in Tonga recently, and their hospital is actually higher up the hill than many of the other dwellings on the island of Tongatapu, which is almost a flat island. So it actually did survive. So where they chose to build that hospital was a strategic location from an environmental health, climate change impact consideration. So there's lots of things like that. Again, telehealth, could we be looking, there's so much travel happens, out of country travel for people to get access to services. Some of those countries are now connected by a very good underwater sea cable that provides fast internet service. So, do you need to come to Australia for certain tests? Could things be undertaken remotely? So that there are some better indicators that we're going to be proposing. So I won't say that there's been any positive action based on the use of that reporting. But again, if you can't measure it, you're not going to be able to manage it. So we're trying to give them measures that are meaningful not only for the region, but at a local level. So if you are the Minister for Health of a country in the Pacific, and somebody suggests spending more money on telehealth, here is good reason why to do it, because in fact, not only will it save you money, but it actually will have a better impact for the environment.
And again, coming back to what you said about measuring what matters, so that it actually starts creating some meaningful step change within the health sector and ultimately for the communities. Now, we've got a question here from Dr. Kaylin Smith. Can you see a role for electronic health records and/or electronic medical management systems for monitoring the environmental impact of healthcare? Do you know of any systems that are using these, LHD or PHN or state level?
Yes, they could. I'm sure that EMRs, EHRs, particularly say for a good example is, let's say, is the My Health Record. In Australia, we should be encouraging clinicians to review that before they then send another referral for an X-ray, MRI, CT. If a patient has had one in the last week, do you really need to order another one? So some of those things are the ubiquitous tools the health system needs. Then we need to start to change clinical practice to encourage that. If a patient shows up to one hospital, is triaged, has a CT, referred off to the next hospital, they have another CT. We should be using our electronic environments. We need much better interoperability between health services, and that's another whole talk about interoperability that we don't have yet. But that is that is what is required for underpinning that kind of change in practice, where we aren't redoing the same things, we aren't re-prescribing the same things, or in fact harming patients through re-prescribing the same things often.
Thank you. Keep them coming, the questions. We've got 8 more minutes left, so please do keep them coming. We also have significant regional vulnerability in Australia, with some areas to be more affected by climate change than others, as we've discussed today. Do we currently have any data that demonstrates the impact of these regional differences on health outcomes?
Yes, there's some work that the AHW has done, which we did for the Australian Commission on Healthcare Safety and Quality. It's called the Australian Healthcare Atlas. Feel free to pop on our website. I don't know when it was last updated, but it's a body of work that's been updated a couple of times that does look at that geographical variance, not only in disease profile, but in health service access. We do know that people in rural and remote areas receive lower level of service for many things than those in major cities. And that body of work was specifically done to try and understand some of that. It's difficult to do a lot of work depending on the underlying data sources. We don't have a lot of good primary care data. We can look at where a patient's Medicare address is registered and look at where they actually access services to start to look at people's, journeys to access service. But as you may or may not know, the Medicare enrolment file is not that great as an address detail, because now that we never go to Medicare, we don't actually update our addresses very often. Most people, when they move house, don't think, oh, I must go to Medicare and update my address. Until we start to improve the quality of the address details for individuals, it's much more difficult. But it is certainly one of those metrics about service delivery access. And as I said before, telehealth has an enormous opportunity to benefit regional and remote areas. And I noticed in the budget last night, the Royal Flying Doctor Service received also a significant amount of additional funding. And I think those kind of programs where we take the provider to the patient rather than the multiple patients to one provider, we can take one provider to see multiple patients. We are starting to improve the shift that we need on the impact on the climate for those services that we're delivering.
And based on that atlas, is there any work that is being considered or being done or could be done with the overlay of the current significant climate impacts we've had with the bushfires and the floods? Is that work that's being currently considered or underway?
Yeah, no, we've done there's published stuff on our website about the impacts of the bushfires. So we did that straight away. The Australia's biennium publication that comes out every 2 years, Australia's Health, some of you I'm sure have heard of. It's due out June this year, and it will have some updated content in there related to that. I'm not sure what might be there about floods. That might be too current, but certainly we've done a whole bunch of work on the impacts of the bushfires in Australia at that significant event just before COVID. Obviously, there's a lot in there about COVID. That's probably overshadowed many of these environmental challenges, but actually floods right now, I'm sure there'll be some issues there. I guess one of the things that, we do know, things like the My Health Record realistically come into their own when, your local GP and pharmacy just burnt down or were flooded out. Having access to those kinds of national resources really do start to make an impact on the individual lives of consumers.
Yeah, absolutely. Thank you. And finally, in summary, could you identify one short-term action that you would like to see the health system take to demonstrate and improve environmental leadership, both in Australia and in the global arena?
I think just putting it on the table. I mean, I haven't heard any national conversation about it being a priority. I haven't heard any international conversation necessarily about it being a priority. I made reference in the presentation I gave to the OECD environmental health climate change indicators. Every one of them starts with the rationale that we need to deal with climate change because of its impact on human health. We need health to start to articulate that and to see that it has a place at the table, I think. Whether that's with the World Health Organization, I do think there is some, comment from the World Health Organization, but probably more about the impact the environment is having on health rather than the impact that the health system is having on the environment. But getting it at least on the agenda at national and international forum would be the place to start. Till it's a priority, no one will do it.
Yes, that's right. Well, look, thank you, Vicki, so much for your time today. Thank you for the access to your presentation and being here to participate in this Q&A. We really do appreciate it. And for those of you that were listening today, if you're interested in learning more about the alignment of sustainability and value-based healthcare, the AHHA's research arm, the Deeble Institute for Health Policy Research, published in 2021, Transforming the Health System for Sustainability, Environmental Leadership Through Value-Based Healthcare Strategy, which explores in greater depth many of the issues discussed today. And so in June, we'd also like to let you know that the AHHA is hosting value-based healthcare founder Elizabeth Teesberg and her colleagues from the Value Institute for Healthcare at the University of Texas to work with professionals across our health system to improve the depth of understanding in theory and practice around measuring what matters, which I think is a really exciting opportunity, and especially considering what we've heard from Vicki today. Crucially, the workshop will include a roundtable discussion on measuring what matters in the Australian context, with the intent of identifying how this integrates with the existing system and where we need to do things differently. It's a great opportunity to ensure climate and environmental sustainability are core to these conversations. So I really do encourage you to register, and more information can be found at our website at ahha.asn.au. The International Federation World Hospital Congress, that's a mouthful, is held in Dubai this year on the 9th to the 11th of November. And the themes for this year will include improvement in the delivery of care and the people agenda. So once again, thank you everybody for joining us today. Thank you, Vicki. Thank you everyone also at the AHHA who is in the background helping me with the slides. We have recorded this session, so it will be available on our website for people to listen back to at any time. Thank you again.